Good afternoon. Thank you for inviting me to present our study on association of genetic variants and outcomes in non-ischemic dilated cardiomyopathy. My name is Luis Escobar, and I am currently a clinical and research fellow in genetic cardiac diseases based at Hospital Universitario Puerta de Hierro in Madrid. As you will be aware, current data shows that dilated cardiomyopathy has a population prevalence of 1 in 250 and is the most frequent cause of heart failure in the young. It is associated with considerable morbidity and mortality and is the leading cause of heart transplantation worldwide. The cardiac myocyte contains many important proteins for its function, including sarcomeric proteins, nuclear envelope proteins, cytoskeletal, desmosomal. And previous studies have shown that as many as 40% of cases of DCM are inherited as a Mendelian trait caused by genetic variant in more than 40 genes that encode this heterogeneous group of proteins. Such genetic heterogeneity likely contributes to the variable phenotype and expressivity observed in DCM. Indeed, there is growing evidence that the clinical course depends on the underlying affected gene. Nevertheless, comprehensive information on the clinical impact of genotype in DCM is limited, and data from large cohorts are not available. With the exception of DCM associated to genetic variants in titin, lamin, filamin C, BAC3, and few others, our understanding of the natural history of genetics of DCM is still poor. So what were the objectives of this study? Well, the aims of this study were to get a further insight into the clinical impact of genotype on prognosis, as well outcomes associated with genotype status, and in this way to compare patients who carry DCM-associated variants against patients without an identifiable DCM genetic variant, to compare outcomes of different DCM genotypes or functional gene groups as well, and to compare outcomes of genotype positive against genotype negative DCM patients according to severity of LV systolic dysfunction. The primary cohort was composed by 1,005 index patients over 15 years of age at diagnosis, recruited from 20 Spanish centers and genotyped with these NGS DCM panels. To expand the genotype positive group and analyze clinical outcomes according to genotype and left ventricular ejection fraction, we add to the Provence cohort 156 genotype positive DCM relatives identified during cascade screening. All patients had baseline clinical assessment, 12-lead electrocardiogram, as well as echocardiographic data analyzed, and patients were followed up as per usual clinical visits. All index cases had been genetically tested using target NGS panels of DCM-related genes from 2015 to 2020. And although the NGS panels could differ in the number of genes, all include more than 50 genes related to cardiomyopathies and all the genes related to DCMs. Our primary endpoint was a combined event of major adverse cardiovascular event that include end-stage heart failure, malignant ventricular arrhythmia, and fatal and non-fatal stroke. Secondary endpoints were end-stage heart failure that include the presence of heart transplantation, destination therapy ventricular assist device, or end-stage heart failure mortality. Malignant ventricular arrhythmia that includes sudden cardiac death, aborted sudden cardiac death, hemodynamically stable sustained VT, and appropriate defibrillator interventions. We also analyzed an isolated left ventricular reverse remodeling endpoint that was defined as either LV normalization, meaning LV ejection fraction improvement to more than 50% with an increase of at least 5% on LV ejection fraction, or an absolute increase in LV ejection fraction by more than 10% and the last follow-up from initial echo. Variants were classified after a systematic review by a cardiologist expert in cardiovascular genetics, Juan Pablo Ochoa, who you may know, using modified criteria of the American College of Medical Genetics. Patients harboring pathogenic or lightly pathogenic variants were considered genotype positive, and patients harboring VUS, lightly benign or benign variants were considered genotype negative. Genes were clustered into functional gene groups based on similar functions involved in biological process, localization into subcellular compartments, and other shared properties. Typing was considered as a separate group because of its specific characteristics of frequency in DCM. So, functional gene groups include the following: cytoskeleton, ZDIS, desmosomal, nuclear envelope, motor sarcomeric, titin, and others. For the functional group analysis, patients who had more than one pathogenic or lightly pathogenic genetic variant in a gene implicated in DCM were excluded to minimize the impact of a compound genotype. In the cohort of 1,005 probants who met the inclusion criteria, genetic testing was positive in 37%. A VUS was detected in around 24%, whereas genetic test was negative in around 39%. With the inclusion of 156 genotype positive relatives, the expand cohort was composed by a 45.5% of genotype positive and a 54.5% of genotype negative patients. This table shows characteristics of patients according to genotype. To compare the clinical phenotypes of patients, we roughly divide the cohort according to genetic test results as genotype positive and genotype negative. Well, the first difference we notice is when we look at the age at diagnosis. Genotype positive patients were significantly younger at diagnosis than genotype negative patients, and were more likely to have a family history of DCM, a family history of sudden cardiac death, and being affected by skeletal myopathy. Genotype negative patients have a significantly higher rate of left bundle branch block. Baseline echo parameters were similar between groups with no difference in LV ejection fraction. So what were the outcomes of these patients? This first cumulative incidence curve comparing genotype positive patients represented by the red line against genotype negative patients represented by the blue line demonstrate a statistically significant higher rate of the primary endpoint in the genotype positive group with a hazard rate of 1.51 after a median follow-up of 4 years. And when we look at the cumulative incidence curve for end-stage heart failure in the left panel and malignant ventricular arrhythmia in the right panel, we also found statistically significant higher rates of either end-stage heart failure and malignant ventricular arrhythmia. Left ventricular reverse remodeling occur more frequently in genotype negative patients with an odds ratio of 0.77. This table shows the composition and distribution of pathogenic and lightly pathogenic variants according to functional gene group in genotype positive province. As in other contemporary cohorts, the most frequently involved genes were titin, identifying around 39% of genotype positive patients, followed by lamin that dominate the nuclear envelope group. The smoke plaquin, the most prevalent gene in the desmosomal group, BAC3, filamin C, RBM20, and MYH7. The worst cumulative incidence of the primary endpoint was observed in the nuclear envelope gene group represented by the yellow line. The cytoskeleton set this represented in the brown line, desmosomal represented by the green line, exhibit a lower risk of MACE than the nuclear envelope group, but higher than the other functional gene groups. A similar behavior was noticed when analyzing end-stage heart failure in the left panel and malignant ventricular arrhythmia in the left panel, where an overwhelming majority of events occur in the nuclear envelope group. Differences were also noted in left ventricular reverse remodeling between the functional gene groups. The titin group had the highest rate of left ventricular reverse remodeling, around 53%. And the worst rate was observed in the desmosomal gene group with around 11%. When compared with the genotype negative group, the left ventricular reverse remodeling rate was lower in desmosomal, nuclear envelope, and motor sarcomeric functional groups. When analyzing the expand cohort, we observe a similar behavior in all the endpoints, with a significant higher incidence of MACE, end-stage heart failure, and malignant ventricular arrhythmia, and lower rates of left ventricular reverse remodeling in the genotype positive group. Genotype and left ventricular ejection fraction were used to perform the last analysis. So when we compare patients with severe LV systolic dysfunction at baseline, we noticed that genotype positive patients with baseline LV ejection fraction lower than 35% had a higher incidence of MACE than genotype negative. This is shown in the left panel. By contrast, there were no statistically significant differences when comparing patients with LV ejection fraction higher than 35%, that is shown in the right panel. End-stage heart failure events occur also more frequently in genotype positive patients with severe LV systolic dysfunction, and no difference were noticed in the subset of patients with LV ejection fraction higher than 35%, shown in the right panel. And lastly, malignant ventricular arrhythmia events were also significantly more frequent in genotype positive patients with baseline LV ejection fraction lower than 35%, and no difference were observed in the group of patients with LV ejection fraction higher than 35%. So in summary, what has the study shown? In the first place, genotype positive DCM patients exhibit worse clinical outcomes in terms of MACE, end-stage heart failure, malignant ventricular arrhythmia, and LV reverse remodeling than their genotype negative patients. In the second place, All the endpoints rates differ depending on the underlying affected gene or functional gene group. And lastly, even when MACE, including malignant arrhythmia, do occur in patients with LV ejection fraction greater than 35%, genotype positive DCM patients with severe LV systolic dysfunction show increased rate of MACE, end-stage heart failure, and malignant ventricular arrhythmia than genotype negative patients with LV ejection fraction lower than 35%. This is a list of the authors who were involved in the study. Without his help and expertise, it would not be possible. Thank you very much from the Heart Failure and Inherited Cardiac Disease Unit of Hospital Universitario Puerta. Thank you very much.